take an alarm. This might be a deep fake. This might be not true. Facebook does somehow this by sampling only the news in the social media with some kind of fact checking. But again, it's not transparent. They inform you that this may violate community, let's say, standards, but these community standards are not transparent. And second, the fact checkers are not uh, uh, trusted always. So it's a big issue in any case. My talk, my session, will be about multidisciplinary research for optimizing healthcare service. We should see in very fast mode why AI now in order to advance healthcare and also about regulations on this and some case studies that I have run so that to understand better this important field. This is a recent book of 2025 regarding revolutionizing healthcare with AI, and not only with IoT. I will not refer to IoT, but only to AI integration. So what makes healthcare unique for us, for researchers, and also for AI? The history starts from 1970. In FAST, the first system was an expert system, the MySyn from Stanford, which could recognize, based on specific features, would recognize diseases. The second was the internist QMR model, based on again diagnosis. There was nothing else at that period. Again, from symptoms to diseases, but here it was a graph-based probabilistic model, which could identify almost 500 diseases with 4,000 symptoms, based on 4,000 symptoms. A huge network, probabilistic network for that period, but it was very difficult to maintain, very difficult to generalize. Also, a certain progress at that period was regarding the probabilistic networks in general, and we can see that these models, not only the first that we saw previously, but this kind of models had not big application, but it was certain application, certain assistance to doctors. In the 90s, in order to finish this short history, we had the neural networks, the first neural networks, backward propagation, etc., which were good in recognizing in diagnosis, again on features and not very many, of course, diseases, but it was successful with several problems. We could not adjust this to clinical workflow, and the generalization was poor. Here are the attempts at that period. You can see a lot of attempts, and you can see also that the number of features was small, and the training here samples were very small in order to make tests. You can see the numbers, not big data, very small data. So why now, after 2008, we increase the number of data. You can see that I have not drawn the picture to 2025. It's 10 times this by electronic healthcare records. So from 2008, not the 90s, up to 2025, we have 10 to 11 rates of increase since, so in 17 years, the increase of electronic healthcare records over the whole globe has increased too much. The problem is, again, however, we don't have data for everything. Although this data is increased, we don't have for all cases. In the near future, we expect even more data. And also, the problem with the data is not that we don't have exactly, we don't have good label data. It's very difficult to label massive data. Hospitals have other priorities, and you understand that to have clean data and not raw data. Now we have increased number of raw data. But if you check benchmarks for training your methods, the data, okay, it might be 100,000 patterns, but not more than this. We don't have millions and billions if we have the HAR. So in life sciences in general, what is the important is to have many cases, as many as possible, labeled, large labeled data sets, because unsupervised methods work. But when we want to go to diagnosis, large labeled data sets is a must. We cannot distinguish very well our data and label them through unsupervised learning. So it's in all medicine, what is the important thing is now from the hospitals, and you can see that Obama's initiative was to create millions of research cohort and core data. And from this point of view, around 10 years ago, we started the healthcare system in USA, in UK, etc. They started to record full cases in electronic healthcare records, and not only. Now these data are accessible. But what kind of data we're talking about? And we mean what kind of data to integrate in HAR and large data sets. We should integrate, of course, lab tests, blood tests, and all these known lab tests results, imaging, many kinds of imaging, PET, fMRI, whatever you can imagine. Proteomics, this is an important also large data coming from genomic data. We have genomics separately. Proteomics is about proteins, of course, and this is critical for analyzing the behavior of the body. And of course, signals, electrocardiogram, electroencephalogram, and many, many other things. But also from IoT devices, other signals, and social media also. Why social media? Because there we have the views of the people, the patients, about their symptoms, how this are connected with the hospitals, what are the sentiments, analysis about the hospital and healthcare in general. So here is an integration of data from many sources. And this should be in an integrated benchmark or data set. This is not the case. We don't have such integrated data now. In order to test our data and models in large data sets, we should not have only one kind of source. If you check Kaggle or other major Amazon, etc., or the Microsoft Azure for data sets, you can see that the data sets are coming from one source. We don't have a lot of multi-source data sets. This is a challenge. This is a challenge, one of the challenges in the current research of models for healthcare, for Medicare. The other big issue that was covered during these years and gives a lot of potential is that through ICD-10 coding, we have nearly all diseases. I believe there is no disease nowadays in 2006 that is not registered in the system and it's not encoded. So you understand it's not enough because we have thousands of diseases, okay? You understand that it's impossible to have, let's say, a neural network to handle all these cases. What we should do is to cluster the cases and have, for instance, distributed intelligence for the different clusters of diseases. This could be done through federated learning and other possible methodologies. We have a lot of distributed now methodologies. So the standardization includes, of course, the diagnosis codes through ICD-10. ICD-9 is now obsolete and is covered by ICD-10. The laboratory tests, the law codes, everything is encoded. The pharmacy, everything is encoded. And also the unified medical language system with millions or more of medical concepts. And here is a big issue, a challenge, but a big progress, because UMLS is the standard language now for everything in medicine. There might be some gaps, but this is updated, and such UMLS is a cornerstone in developing systems. Why now? Why, apart from these big progresses, why now to have AI? Because we have now many machine learning and deep learning and general AI, including fuzzy logic. We have good algorithms, very high dimensional. They can not solve, but they can touch a bit the high dimensional feature space, for example, through regularization techniques. We have unsupervised and semi-supervised learning, good algorithms, and of course, the deep learning techniques. Actually, we have also that anyone can play with these models because of Python and scikit-learn, TensorFlow. We have the democratization of machine and deep learning. Anyone can test models without even having knowledge of the models. Everyone can test. You, even your father, your mother, anyone with let's say, the assistance of AI chatbots, anyone can test. This is huge. The industry is long involved through a lot of time, uh, since 2000, since almost 2000. And now the interest is exploded. It's exploded because what is needed is not the diagnosis exactly. The diagnosis now can be good, but in the level of a medical assistant, not of an expert, a very expert, let's say, doctor. In junior, can compare with junior doctors. And this is good, of course. It's a help for countryside, let's say, hospitals with no many experts. Digital assistance is now a very good help there. But experts do not need so much the digital assistance in diagnosis, except in very extreme cases, maybe. But what they need mostly is personalization of healthcare. As we talked previously about personalization of media, advertisement, marketing, and so on, now the major issue with AI is personalization of everything. Personalization of education, personalization of medical care, personalization of marketing, and so on. Everything now can be personalized. This is huge. This is a big challenge, however, too, because as we saw previously, there are so many challenges and we don't have enough filters and trust in order to have the personalized medicine, for instance. How to trust unexplainable black boxes? Difficult. But while these are challenges in general, we have more challenges in the emergency department, for the enhanced medicine care, the EMC department, and most of all the ED, the emergency department. What is the important here? The important here is we don't have many beds, many positions in order to have such care. Second, limited resources in general, doctors, etc. It's very time sensitive, and the decisions also are very critical. You understand the criticality. If someone needed the emergency department is not there because of lack of resources, then it might be difficult to survive. So the emergency department, ED, has very special requirements. You can see that we cannot have, this is in USA, but in Europe, we have similar issues. We need around 500, from 300 to 500,000 cases per year, with specialist lab tests. We need extensive data in order to judge, and you understand we should judge in real time. This is not easy. It's difficult, and what we need is the assistance of deep and machine learning. The important things here is about machine and deep learning is that they can help in the decision making, especially in triggering the clinical pathways. What kind of, let's say, lab tests should be done in order to help doctors regarding the whole clinical pathway, even what kind of medicine should be given, how critical is the situation, etc. We know many cases that the principal doctor is very expert, the surgeon, let's say, but the rest may not be so expert. So here in surgeries and in other aspects of medical intensive care, we need such a kind of help. But one important thing, maybe the most important, when we have experts, is to have context-specific displays. And this means the doctor cannot treat in real time big data from all lab tests, for all images, for you understand that this is impossible. So we need filters and context-specific displays in order for the doctor and the expert to decide. Risk stratification. This is very big and has to do with what kind of people should be selected, what kind of cases should be selected in order to be in the ED, the emergency department. And of course, documentation. Now documentation can be automatic. You know, from our meetings, any kind of meeting, we have the read assistant, the meeting assistant, read AI, for instance, or whatever. Zoom has also its own assistant. So we have all checked that the assistant makes a good job. And you understand that also, even in the more expert case of clinical documentation, they may have very good results for the doctors. So the clinical pathway means, of course, that now the systems can be in the clinical practice. Now, it's not anymore the big challenge. The system can be in the clinical practice. They are integrated with the clinical practice, not only with the digital sources like database, etc., cleaning HIR, integrating HIR, etc., but decision making and prediction analytics. So the clinical pathway is very important. Also, you can see a context-specific display based on the symptoms reported by the patient, who can have a fulfillment, let's say, of the displays in order for the doctor not to interview just, but to see what really happens with the patient in all aspects. In an interview, someone may forget something, but in a system, automatic interview with all possible questions, because a doctor, cannot make all possible questions, maybe only the critical ones. But based on the lab tests and based also in the interview, in the integrated interview, I mean, doctors, the system, and so on, then the picture for the expert who will judge all this information, it's much clearer. Now, risk stratification, as I told you, has to do with the admission. And what I will present soon in the next 10 minutes will be about a project we had for admission. Admission to intensive care unit. You can see ICU. And also during ICU timeline, what will happen to the patient? So maybe severe sepsis. This should be identified very early. I know cases in Greece and in other countries that the experts did not did not understand that sepsis was underway, and we lost humans this way. So it's a very important issue. This is an important table leading to real-time predictions for the emergency department. All these cases are important for the emergency department. So we should have a decision-making system for the prediction analytics and for judging the case. And of course, improved documentation, because on all previous interviews, lab tests, notes of the nurses and the doctors, the system can provide an improved and a very improved clinical documentation with all aspects, including complaints, of course, as I have put here. And so complaints now could be automated, the collection of all complaints for the intensive cure, for medicine, for whatever. So in order to have massive analysis of the complaints of patients, in order to improve clinical pathways, clinical documentation, clinical Medicare, whatever, this is a big help and a big application of AI in healthcare. And as you understand, this is a challenge, still a challenge. We don't have, so we have successful, but not solving clearly these issues. You can see also chief complaints per week. In the past, due to the manual system, there were no complaints. Don't tell me that this means that the hospitals were better, okay? But now, with increased capacities of AI and automation, you can see that we have the people can complain without fearing, because they say this to the doctor or the nurse, they say automatically to the system and anonymously. If we zoom here to what is important for a patient, is because one second thing is not decision making, but decision making based on prediction analytics. Again, the issue is admission control. Who will be in the ICU unit? So you can see the patient here, and we need during a big period, let's say 10 years. Why 10 years? Because the majority of diseases have a period of 10 years in order to be sure that the person is cured or not. So we have demographic data, medications in hospitals, in whatever, lab tests, medical claims, whatever. All these are in the big effort of standardizing how to foresee, how to predict the new cases of a patient, personalized medicine, based on his full past. So what is the important here is a temporal modeling of disease progression. This is huge, because you should understand that a patient here may be having thousands of records. How a doctor to analyze this data? It's impossible. This is the need for AI and automation. So the temporal modeling is now possible through AI, machine learning, deep learning. The issue here, as you understand, is based on different stories of patients in similar cases, okay, in similar cases, you know, AI excels in finding patterns. It might be much better than us because we cannot check thousands of records. It's impossible. But AI can check billions of records and therefore can find similarities and therefore make predictions of what will happen. You can see the associations, similar cases here, what happens here, and how to predict the rest. You understand how big is this issue, and much bigger is not to predict what will happen in general, but what will be done through different drug selection. You can see from statistics of many patients, of course, what happens with drug A, what happens with drug B, and therefore, what will happen? What will be the success, drug A or drug B? For the personalized case, because we know in general that drug A might be good for, let's say, for cancer. And drug B is good, but we know in general. How can we know with this patient? Because not all drugs are fitting with a patient. Sugar level, for instance, control. Not all patients fit with sulfogate, which is for insulin resistance, for instance. How to know this? Only if you have previous data. All this data, based on all this data, the system can say drug A or drug B, and based on this to see the progress. This is the most important thing for personalized medicine. Okay, the many questions and challenges of AI, I will concentrate, because I don't have any more time, I will concentrate on two things: explainability and bias. These are the most important challenges in nowadays application of AI. The systems are black boxes. We don't have very good explainable algorithms, and the data are not clear, as I told you previously, because of the difficulty of labeling data and so on. So we have biased data, not all needed data. These are the challenges. And what makes healthcare different? This is the first, very little data, labeled data. Raw data who have billions, labeled no. And this, of course, might motivate the development of new algorithms, semi-supervised or unsupervised. Also, we have few number of samples in order to have a Medicare system with personalized Medicare. Personalization needs a lot of samples. You understand? If our data are not labeled, how to have big numbers of samples for specific cases in order to have personalization. It's almost impossible, seems impossible, but I believe in the next 25 years, we will have big numbers in order to have true personalized medicine. And you understand also that we have missing data even for such samples and not regular time intervals. We understand that time intervals were according to medication. So we need different algorithms now with predictive analytics based on irregular time intervals. So it's a big issue also, apart from benchmarks that I have used a lot, to share, to have sharing agreements and medical case sensitivity, to share data from UK to Greece, from Greece to USA, etc. We understand this is a big issue, and to anonymize also data, it's a big issue. We have algorithms, but you know, from images, it's difficult to anonymize things. From keywords or from metadata, you can easily anonymize. But from images, for instance, how? It's not easy. The difficulty also of deploying ML. You may know that there is no a big company like Google. And why Google doesn't provide a medical healthcare system? Why? Because they cannot deploy successfully such a system. If they could deploy, you would see Facebook, Google, whatever, to deploy such systems. You understand, therefore, that the whole issue is a challenge. I will skip several things, but I want to concentrate here that what is very important in deploying ML and deep learning, etc., is to build anomaly detection rules. You can see clustering here, but we need to improve, and this is the important thing, to improve the accuracy of the clinical decision support alerts. Up to now, 2026, we don't have all relevant rules for early detection, early alarm, even for sepsis. So, for instance, a question, if the patient is over 65 and has not received the vaccination, suggest one. This was derived from the COVID period. So alerts is a big issue, and we want to improve alerts. Also, predictive antibiotic resistance. There are some rules. There are some rules based on such analysis here, but they do not cover everything. Also, more issue, the congestive heart failure. We have many cases now. We don't know the reasons for heart failures. So there are huge data sets or big data sets for critical healthcare in the main sites. You can have anonymized. We can have many more, but anonymized are in the range of 100,000 K patients. For multiple myeloma, for Parkinson's disease, for mammography, for pathology in certain cares, for lung cancer, for diabetic retinopathy, and so on, and so on. So you understand that building data sets is a huge and very complex issue and very complex challenge. What I want to emphasize and finish now is about the enhanced care management, ECM admissions, is a project that I worked with since the previous 5 years. It stopped last year. And the important thing is how to predict whom to admit. This is what is provided in general by the records. We have, of course, the patients, we have the providers of tests of medicine, the payers, okay, the one who are billed us, therefore, and stakeholders, the hospital, etc. All this should be understood as an integration, and this means that the patients who should be admitted should not violate the possibilities. And what I mean is everyone can be in the intensive health care, but it should be considered under costs. And so, for instance, in hip and knee replacement in USA, what happens is that we can train the system about who will be real beneficiaries. You can see how we train such data. 3,000 dependent variables, etc., is for hip and knee replacement. And to have prediction analytics about these cases. So if we see here, we see something important, that there is a mortality rate for all of this. And the mortality rate is sometimes is big, you can see. Sometimes is very big. So we have a question here. Should the mortality rate of case 1, category 1, if we don't have intensive care beds, can we bring this into the intensive care unit? When the mortality between 1 and 12 months is not in favor of the patient? This is a big question. And here we need AI. This is a challenge because the subject is very sensitive, as you understand. Also, examples of pediatric conditions. Who needs absolutely now the healthcare in the intensive care unit? Is the doctor will judge. He needs assistance here by managing all data with predictive analytics, breast cancer, and so on. Okay, I stop here because I don't have more time than this. And I believe I have covered the basic things in this multidisciplinary research. Is not only AI research. This needs a research coming and actions coming from many sources, including hospitals, including big data providers, including doctors, of course, nurses, and so on. We need, first of all, real big data in order to have personalized medicine. And personalized medicine, according to which drug may have the most success, this is the biggest challenge nowadays. But we are in good progress. Also, regarding the admission in intensive care unit, which is a very critical issue for nowadays limited resources in healthcare units, AI can offer the capacities for predictive analytics-based decision making, whom to admit, because we can predict mortality rates within 1 to 12 months. So why to be in the intensive care if his or her mortality within 1 to 1 year is very low? Is very low the health, let's say the survival rate, and very big the mortality rate. These are, of course, also ethical questions, because what does it mean? I have mortality possibility of 45 or 50%. I have another 50, but you understand the issue when you have limited resources, you should pay attention also to the mortality, because we don't have the resources. The stakeholders might say that, okay, we cannot afford such cases. Big ethical issue. Thank you very much for your attention.
Yeah, thank you so much, sir. I think, sir, you want to conclude or you want to
No,
continue?
I have concluded.
Yes, yes. So big congratulations, sir, for the nice presentation on AI and about the machine learning.